Good afternoon, colleagues, and welcome to the departmental colloquium. It is my absolute pleasure to introduce to you this afternoon Professor Jennifer Moodley, who is the Director of the Cancer Research Initiative at the Faculty of Health Sciences at UCT, as well as the Deputy Director of the South African Medical Research Council's Gynaecology Cancer Research Centre and Honorary Clinical Professor in the Centre of Prevention, Detection and Diagnosis at Queen Mary University of London. She is a public health medicine physician with experience in health systems research, epidemiology and public policy development. Her research interests include understanding pathways to cancer care and improving timely diagnosis of symptomatic cancer, and she currently serves as a collaborator on the Lancet Commission on Cancer and Health Systems and is a commissioner for the Lancet Commission on Women and Cancer. Professor Moodley, thank you very much for making time this afternoon to come and speak to the department, as well as individuals who are members of our Colloquium, which is both an online community as well as an email community that we've had running for many years. So thank you so much for being here, and we are very much looking forward to your talk this afternoon. Colleagues, we will take questions at the end, and in the meantime, if you can please keep your microphones on mute and your cameras off. Thank you very much for being here this afternoon to all of you. Over to you, Professor Moodley. Thank you.
Thank you so much, Bronwyn, for that kind introduction. So I'm confirming that you can see my slides.
Yes, I can. Thank you.
Great. Thank you. Okay, so let me start. I want to start by asking you to imagine for a moment the person who notices a change in their health, perhaps a persistent discomfort or a symptom that does not go away. Now, this initial discovery can be quite a daunting experience, and many questions arise. What could this symptom mean? Is it serious or not? What steps should be taken next? And it is at this crossroads that our healthcare system is put to the test. What do we understand about the journey that this individual is about to take? Can we provide the support, knowledge, health, and other resources needed to guide individuals toward a timely and accurate diagnosis? Today, I want to focus on this journey from symptom discovery to cancer diagnosis. I'm going to start by giving some contextual information on the burden of cancer, then speak about frameworks that can guide our understanding of this pathway, present some results from our Awaken study, and discuss a little bit our ongoing Awakened study, and then open up for discussion and any questions you might have. So in 2019, there were 55.4 million deaths worldwide. The vast majority, 74% of these deaths, were due to non-communicable diseases. And cancer was the second leading non-communicable disease, accounting for 9.3 million deaths. Let's move on to the number of new cases, and this is 2020 data, which is the latest and comes from the Global CAN Registry. And in 2020, there were just over 19 million new cases of cancer for both sexes and across all ages, with breast cancer being the leading cancer, followed by lung and colorectal cancer. But of course, this pattern differs depending on the different settings. So, for example, if you look at the top pie graph on the right, that shows the distribution of cancer by site in very high Human Development Index countries. And you can see pretty much like the picture on the left, with breast followed by lung as the most common cancers. But if you look at the bottom right pie diagram, you will see, yes, breast cancer is indeed the leading cancer. But then the second cancer, the second most commonest cancer seen is cervical cancer in that orange slice of the pie. Now, cervical cancer does not even feature in the top 10 cancers for very high Human Development Index. So this picture of what cancer you see does differ in different settings. What about the projected cancer burden? It is predicted that by 2040, this number of 19.2 million cases will jump up to 28.4 million new cases seen in 2040. This figure shows the estimated number of new cases over 2 time periods, 2020 to 2040, across the 4 different HDI regions. And the colored circles show the figures for 2040, whereas the open circles, uncolored, show the figures for 2020. So on the right-hand side of the figure, you can see that for high and very high Human Development Index countries, they start off in 2020 with a very high baseline of cases, 7.3 million and 8.93 million new cases in 2020 for high and very high HDI countries, respectively. Even though they have good screening and early detection programs, they're still projecting an increase of 56% and 32% relative increase for high and very high Human Development Index, which poses a problem to their health system. Moving over to the left, you see that low HDI and medium HDI countries start off at a lower base in 2020. But what is concerning is this high projected increase. Just looking at low HDIs, you can see that this number is going to go up from 0.65 million to 1.3 million, representing a 96% relative increase in the cancer burden. And what we know is that low and medium HDI countries, currently their health systems are unable to cope with this burden. So we really do need to address this cancer burden and look at how our health systems can improve in managing the cancer burden. So coming to the African continent, just in terms of numbers, in 2020, there were just over 1 million new cases and just over 700 cancer deaths. And we know that that figure is likely to be an undercount because we don't have good systems to pick up this data. And the 2040 figures just shows the almost doubling that we can expect by 2040 in terms of new cases and deaths. There are also a number of unique features of cancer in Africa. Worldwide, the burden of cancer is higher in men compared to women, but this is reversed in Africa, where 57% of the cancer burden is seen in women. Largely, this is due to the high burden of breast and cervical cancer. And we know that women having cancer or dying from cancer has a large intergenerational effect. In 2020, of the estimated 1 million maternal cancer orphans worldwide, 370,000, so that's just over a third of those cases of children whose moms died of cancer were in Africa. Then turning to infections, infections that cause cancer, and looking at the infection attributable age standardized incident rate. Worldwide, this figure stands at 25 per 100,000 person years. Whereas in sub-Saharan Africa, this figure goes up to 33 per 100,000 person years. So a large portion of our cancers are due to cancer, and largely this is the human papillomavirus that causes cervical cancer. Another unique feature of cancer in Africa is the high proportion of people that present at an advanced stage, estimated to be 65% for breast cancer and 66% for cervical cancer. And we know that presenting at an advanced stage means poor survival, poor outcomes, increased costs, both to the person, the family, as well as to the health system. And then, of course, the stigma that gets attached to cancer, where it definitely becomes known as a death sentence. So early stage of diagnosis becomes an important goal of any comprehensive cancer control and care program. There are 2 usual routes to getting a cancer diagnosis. One is through screening, which is really meant to pick up asymptomatic persons, screen them, and treat them, but sometimes you pick up cancers through that route. By far, the commonest route to pick up cancer is through symptomatic presentation, whereby a person, like the person I spoke about initially, presents with a symptom. And here, what we really want is to try to get earlier presentation and timely diagnosis so that we can that the end result is downstaging of that cancer. So I want to focus my talk and the work I'm doing on symptomatic presentation. So a brief word about frameworks that can guide us in understanding this pathway. The first is the model of pathways to treatment. And this framework speaks of 5 key events along the pathway shown in the yellow boxes. The first is the detection of some sort of bodily change. The next event is then perceiving that this change is a reason to visit a healthcare provider. Not yet visiting, which is the next step, which is the first consultation with the healthcare provider. The next major event is diagnosis and then the start of treatment. Between each of these major events are important intervals shown in those pink squares that we can monitor and see how we're doing in terms of improving this pathway to care. And these intervals between the detection of a change and perceiving a reason to visit a healthcare provider is referred to as the appraisal interval. Then from perceiving to actually making that first visit to a healthcare provider is referred to as the help-seeking interval. And together, the appraisal and help-seeking individual is often referred to as the patient interval. Then between first consultation and diagnosis is diagnostic interval, and the last interval is the pre-treatment interval. Now the green long squares running, the green rectangles running across are the contributing factors along this pathway to treatment. And this framework divides it into patient factors, healthcare provider and system factors, and disease factors. Although they're presented as discrete rectangles, we know that these factors often intersect, making that journey a lot more complex. This journey is not linear, and those blue circles are there to indicate that the process of moving from one interval to the next involves many deliberations and decisions, and it's quite an iterative process. The second framework is the WHO framework on steps to cancer diagnosis and care, and it speaks of 3 important steps. The first being awareness of symptoms, then seeking and accessing care for that symptom. The second is clinical evaluation, diagnosis, and then staging of the cancer. And the last refers to access to treatment. So focusing on that first step of symptom awareness and accessing care, there's some important questions that we would ask ourselves about this step. Is the public aware of cancer symptoms and signs? Are we able to measure public awareness with validated, locally relevant tools? And it's important that they are validated locally, because these can be, the information we gather from using these tools can inform development and evaluation of evidence-based interventions. Another important question is to understand how bodily changes or symptoms are appraised by individuals. And it was these questions that led to the first study I'm going to speak about, the AWAKEN study, which focused on breast and cervical cancer. So AWAKEN stands for the African Women Awareness of Cancer. And this was a collaborative study across 4 institutions in 3 countries. And I've put the logos down of the number of funders that contributed to this project. This slide is just to acknowledge the large team of investigators and collaborators on this project, as well as show the diverse range of skills that this team brought to the project. So when we had a look to see were there validated tools to measure breast and cervical cancer awareness, we found that there were none. And so our first objective with this study was to develop and validate a tool to measure breast and cervical cancer symptom and risk factor awareness, as well as lay beliefs, help-seeking behaviors, and barriers to seeking care. And we wanted to do that in 2 countries in sub-Saharan Africa. Once we had the tool, we wanted to use it to measure, in fact, all of those things in rural and urban settings in these 2 countries. And then we wanted to qualitatively explore symptom appraisal and help-seeking behavior among women who had possible symptoms. And lastly, to explore primary care level provider interpretation and management of potential breast and cervical cancer signs and symptoms. So we did this study in South Africa and Uganda. In South Africa, we worked in the Western Cape in Khayelitsha and in Lusikisiki, which is in the Eastern Cape. And in Uganda, we worked in Northern Uganda in Gulu, which was our urban site, and Moya, which was our rural site. Really critical to the success of this project was the community partnerships that we formed, and we had established project advisory committees in each of our sites. These committees included local councillors, traditional healers, members of NGOs, as well as healthcare providers and managers. And they were really critical to negotiating access for these community-based studies that we were undertaking. Really helped us with sampling in very difficult terrain, with the recruitment of field workers, provided input on the tool so we were able to get local feedback, and also were a forum through which we could feedback results. So let's start with the first objective, the development and validation of the Awaken tool for breast and cervical cancer. This followed a well-known 4-step process. Step 1 involves generating items or questions for the tool. And to do that, we reviewed existing tools. Now, these were the tools that existed in high-income country settings. So we had the cancer awareness measure tools and the awareness and beliefs about cancer tools, which were developed in the UK for use in their settings. We also did a scoping review to look at the kinds of questions that were being asked and in African settings and the experience with using those questions if that was available. Once we had a list of questions, our next step was to refine this, the tool items. And we did that through having cancer experts across sub-Saharan Africa score each item of the tool and then provide comment on the items. We also did think aloud interviews with women to see how the questions were being interpreted. Once we refined the tool, we went on to the next step, which was doing psychometric testing to validate the tool. And for this, we had 3 groups of participants: community participants, non-medical staff at UCT who completed the questionnaire twice, 2 weeks apart, and then cancer experts again across sub-Saharan Africa who also completed the questionnaire. And we tested for retest reliability, construct validity, internal reliability. Once we had a tool that was valid in English, we then went on to develop the local language versions of the tool. In our case, this was a tool in isiXhosa and Acholi. And for this local language version process, we did translation, back translation, got cancer experts that were familiar with both local language and English to look at equivalence of meaning and provide comments and feedback if there were any discrepancies. And we also did think aloud interviews with the local version of the tool, local language version of the tool. So this was a lot of work that took more than a year to do. And so I'm really doing a big summary by giving you just 3 points on the results to say that the tool we found to be stable over time, able to discriminate well between expert and community level knowledge, and had good internal reliability. So a bit more about the tool. The tool has 115 questions in total, but it can be divided into breast cancer and cervical cancer there and used independently. So there were 50 breast cancer, specifically breast cancer questions, and 41 cervical cancer questions. And then there were questions that applied to both, which were socio-demographic and barriers to seeking care questions. For both cancers, we started with introductory questions. And then we had questions on risk factors and symptom awareness. Both of these started with an open-ended question, which was totally unprompted. We then went on to a series of prompted questions, and these were prompted based on evidence-based risk factors and symptoms. Interspersed between these prompted questions, these evidence-based questions, we also had questions on lay beliefs. We interspersed them so that they could serve as distractor items in our questionnaire. But at the same time, they gave us valuable insight into lay beliefs that we had picked up from our scoping review. For the breast cancer symptoms, we also commissioned images of certain symptoms to be drawn on dark skin because literature had shown that this was a gap. And one of the research groups working in Kenya had mentioned that this would be very useful. So we have these 3 images that we used and found to be very useful in explaining or showing patients symptoms. Then there were questions on confidence in detecting symptoms, help-seeking behaviors, socio-demographics, and barriers to seeking care. So all of this validation process, as well as the final tool, you can read more about it in our publication. You can also visit our website shown on the right, www.awaken.online. And essentially, if you go to the website, you can get the publication. You can also download the tool, download the images, and there's also some guidance on how to use the tool and how to score the various awareness factors. And now we have evidence that the tool is actually being used elsewhere. So once we had the tool, we then embarked on our cross-sectional community-based survey. And in this survey, we interviewed women that over the age of 18 with no history of breast and cervical cancer. We did random systematic sampling of households in both the rural and urban sites that I showed you earlier, and then randomly selected 1 woman per household. We did face-to-face data collection using a handheld tablet customized with the Awaken tool that also had offline capability. Between August and December 2018, visited just under 2,000 households and interviewed 1,758 women. So what we found in terms of breast cancer awareness was that a large proportion of women had heard of breast cancer, 91%. But once you ask more detailed questions, then the gaps became, you could see the gaps. So in the open-ended question, so the unprompted question, which really tests recall, only 9% of participants could recall at least 1 risk factor. Recall of symptoms was higher at 78%, recalling at least 1 symptom. Questioning with prompted questions showed higher awareness, and this tests recognition. Here, 95% could recognize at least 1 risk factor and 99% at least 1 symptom. Family history was the most commonly recognized risk factor, and for both recall and recognition, breast lump was the most common symptom. In South Africa, there was we found that the location was significantly associated with symptom and risk factor awareness, with greater awareness in urban compared to rural settings. We didn't find that urban-rural difference in Uganda, but relationship status was associated with risk awareness, and age, so your older age compared to younger age, associated with higher symptom awareness. Looking at cervical cancer, again, a large proportion of women had heard of cervical cancer, but once you went deeper, we saw the gaps. So with the open-ended question, 38% could recall at least 1 risk factor and 58% at least 1 symptom. Again, testing with prompted or testing awareness using prompted questions, showed higher recognition. Overall, 99% could recognize at least one risk factor. However, when we looked at individual risk factors, you could see some gaps. 47%, so that's just under half, did not recognize that HIV infection increases the risk for cervical cancer. And this is in countries where HIV has a high prevalence. About a quarter did not recognize that HPV infection was a risk factor for cervical cancer. And almost a third did not recognize that not having regular cervical screening increases one's risk. Overall, 98% recognized at least one symptom, and the symptoms recognized, importantly, were an offensive discharge as well as abnormal vaginal bleeding. In South Africa, once again, we found that awareness for cervical cancer symptoms and risk factors was higher in urban compared to rural areas. In Uganda, no such geographical differences, but education was significantly associated with risk awareness, secondary being higher than primary or no education, and relationship status was associated with symptom awareness. Then our questionnaire was also able to pick up information on lay beliefs. The commonest lay belief for breast cancer overall was keeping money in one's undergarment. This was seen as a risk factor. It came up in 21% of our participants in the unprompted questions. And then in the prompted questions, 88% of participants endorsed that belief. Other beliefs related to wearing a tight undergarment or storing your mobile phone in an undergarment. For cervical cancer, the commonest lay belief in South Africa was poor personal hygiene. And in Uganda, it was vaginal insertion of herbs, creams, and various objects. And it's important to understand these lay beliefs, because if someone endorses these lay beliefs, it could affect their pathway, particularly if they are not practicing that particular belief, such as keeping money in the bra. They may then think they're not at risk of developing cancer. It's important in our education to not only address the evidence-based factors, but also the lay beliefs. We asked questions of participants related to if they should develop a symptom, what do they anticipate their barriers and help-seeking behavior would be? So most women said that they would seek care within 1 week. 86% of participants with breast cancer and 88% with cervical symptoms. And we know that this is very different to the facts we see when patients actually are diagnosed with cancer. They've often waited for a long period. And this discrepancy between hypothetical help seeking versus actual help seeking is actually well documented in the literature and is seen both in high and low income settings. 39% of our participants anticipated at least one barrier when seeking care. 15% had at least one emotional barrier, and this was things like being afraid of what tests might show or even undergoing tests. 23% said they anticipated at least one health service barrier, such as waiting in queues. 28% said they would anticipate at least one personal practical barrier, which, for example, included financial barriers. And indeed, lack of money for transport or clinic costs was the most common barriers reported by 25% of all participants. More participants in Uganda than in South Africa anticipated this financial barrier. But in South Africa, you do see, again, this urban-rural difference in anticipated barriers. For South Africa, rural location was associated with longer anticipated times to care for both cancers, and you can see the adjusted prevalence ratios there. For both cancers and in both countries, women who reported more barriers were significantly less likely to anticipate seeking timely care. When we did the interviews, we also came across women who had symptoms. And so we did in-depth interviews with these women with symptoms to understand their symptom appraisal and help-seeking behavior. In total, we interviewed 23 women in Uganda, 10 with breast symptoms and 13 with cervical symptoms, and 18 women in South Africa, 10 with breast symptoms and 8 with cervical symptoms. So what did we learn from these interviews? We found that the whole symptom appraisal and attributing the symptoms to something was a complex and very iterative process. For cervical symptoms, some attributed it to HIV, others to use of contraceptives, and some to sexually transmitted infection, often relating this to partner infidelity. Breast changes were attributed to daily activity, tight undergarments, or benign lumps. Some considered that this could be cancer, and this was based on either information received at the clinic or the persistence of symptoms. But many of the participants were really unsure as to what their symptoms meant. Many discussed or disclosed to family and close friends, and the reasons for this varied. They included discussing the symptoms, to seek advice on causes and to take further action, to seek financial support, to attend the clinic, and to seek support for absence from household duties when they attend the clinic. Others preferred not to disclose, fearing stigma and gossip, and that's illustrated in the quote from a participant from Uganda below. We asked questions about what challenges they might anticipate if they accessed care. And these challenges they anticipated related to their home care commitments, problems with physical access to clinics, safety concerns, and financial constraints. And these are just some of the illustrative quotes for you to get a sense of the data. The first quote is from a rural participant in South Africa, who, in order to get to the clinic, needs to first walk, then cross a river, and then walk through fields. So a difficult journey, and added to that is the fear of being robbed on that journey. The second participant from Uganda speaks of the difficulty of access to finances in order to pay for transport to get to the clinic. And the third, a person from South Africa who said she would be unable to go because she needs to gather firewood, not just for her personal use, but also this was a form of income. So giving up that would mean foregoing some income. Participants reported mixed past experiences at facilities. Some were encouraged by positive experiences, but others were discouraged by past staff judgmental attitudes, long queues, and lack of equipment. And you can see that in the quotes below. The first from South Africa, where the participant says the providers shout at them, and added to that, they might not have the equipment to do a pap smear. Participant from Uganda saying they were discouraged because there were no drugs at the facility. So if they needed anything, they would have to go outside anyway for that treatment. In terms of seeking biomedical care, in general, there seemed to be more prompt care seeking for cervical compared to breast symptoms. And this was largely related to the impact of symptoms on participants' personal lives. So in that quote, you can see a participant going to the clinic largely because the smell of the discharge was so offensive that she needed to have it investigated and treated. Most participants were really strongly encouraged by family and friends to seek care. And I think this just highlights the importance of our health education initiatives, not just focusing on women, but really opening it up to the broader community, because they play an important role in improving that pathway to accessing care and getting a diagnosis. In terms of traditional and complementary care, some participants were skeptical or even negative towards traditional medicines and healers. Others used both traditional and biomedical practitioners, largely depending on the perceived seriousness of the symptoms and the cause of the symptoms, as well as responses to medicine. So you can see in the first quote from a participant in our rural site, where she speaks of having grown up with the herbs, but that the herbs would be used if it's not so serious. If it's something more serious, then a visit to the doctor is preferred. And in the second quote, a participant who took traditional medicines but without success, and so then was encouraged by her partner to go to a doctor to get the right information. These are just photos actually of our field workers who were journeying from the clinic to the communities to interview women in their homes during this surveys. The two on the left show our field workers going through fields and across hills as they move from the clinic to the participants' homes. The next two pictures show the transport difficulties, and these are pictures in Uganda where our vehicles were bogged down in muddy roads and we eventually resorted to using motorcycles. And the last picture, just an aerial view of the really dense areas that we had to navigate in both our urban sites. Now, these are the journeys that our field workers took, but it would be the same journey that participants would take should they develop a symptom. And so you can see that this is really a difficult journey to take for a symptom that you really may not be sure about. Our last study looked at primary care level provider interpretation and management of potential breast and cervical cancer signs and symptoms. And you all know that primary care level providers are really the gatekeepers for access to our public health system. For this part of the study, we did in-depth interviews with 51 primary healthcare providers, 24 in South Africa and 27 in Uganda. And these in-depth interviews incorporated vignettes or scenarios. We had 2 breast and 2 cervical scenarios, and the content for these were informed by the preceding Awaken studies. They were developed really to capture provider symptom interpretation, their reasoning and judgments, and management referral and feedback issues. So the key findings from those interviews, and we found that the proposed history taking and clinical assessment by providers was really very comprehensive. The possibility of infectious causes was considered for both breast and cervical symptoms, sexual assault and HIV for those with cervical symptoms, and cancer was also considered as a potential diagnosis for both cervical and breast symptoms. Issues raised included the need for provider training and support, problems with cumbersome referral systems, lack of feedback, and in addition, the providers reported on their perceptions of patient financial and awareness challenges, which really mirrored the findings we had found when we interviewed participants themselves. So to summarize from Awaken, we found that there were gaps in community knowledge of breast and cervical cancer symptoms and risk factors. There were really very difficult journeys to care impacted by finances, competing priorities, geography, and poor infrastructure, and that primary care providers wanted to be better supported in managing persons with potential cancer symptoms. So for our next study, we were really interested in addressing the gaps the gaps in knowledge in the public sector, as well as we wanted to better support our primary care providers, and then also to understand this journey, what happens once a primary care provider has seen a person with a symptom, what is that journey to diagnosis? So this then takes us to the next study, which is the Awaken study, which is currently ongoing. And we really wanted to keep our logo and our acronym as far as possible, but we had to change what the acronym stood for because in this study we included colorectal cancer. So Awaken stands for African Awareness of Cancer and Early Diagnosis. It's being conducted across 3 universities and is funded by the National Institute for Health Research. This is just acknowledging the large team of co-investigators. We also have a large team of collaborators. It's a 4-year study and we're about reaching the midpoint of the study. We're working in the Western Cape and Eastern Cape in South Africa, and this time we're working in Zimbabwe, in Harare and Bulawayo. And as I mentioned, we're also including colorectal cancer in this study. So the key research question for this AWAKEN study is, can we use innovative approaches with digital technologies in primary care and public health to advance the early diagnosis of breast, cervical, and colorectal cancer in Southern Africa? And we're doing this work through 3 work streams. The first work stream is really helping us understand and map the pathway to referral and diagnosis. For this, we're doing a cross-sectional survey of just over 1,100 newly diagnosed patients. So here we're starting at the other end of a person who's already diagnosed with cancer and asking them to reflect back. And we're measuring the key time intervals that I put up that were part of that model of pathways to treatment framework. And these are the intervals between symptom awareness to first facility visit to date of diagnosis. We're also looking at stage of diagnosis, socio-demographic, and awareness factors. Then importantly, we're really doing a deep dive into health expenditure, trying to work out factors that are associated with financial catastrophe. We're almost completely done with our health facility audit, which is being done in primary, second, and tertiary levels of care, taking stock of a number of capacities: human resource, infrastructure, information and record keeping systems, as well as technology capacity. We're doing interviews with healthcare workers, again, across primary, secondary, and tertiary facilities, looking at the barriers and facilitators they face in terms of triage and diagnosis, as well as referral across the different health facility levels. And then importantly, considering our interventions, looking at technology acceptance and usability. Workstream 2 looks at development of these tools, and for this we are going to draw on the findings from AWAKEN as well as from Workstream 1, look at existing relevant policies and guidelines, input from collaborators, and we're undertaking 2 systematic reviews, one on digital interventions to support providers and the other on barriers and facilitators to use mHealth tools by the public. All of the above will then underpin the development of a symptom management and referral e-tool for primary care providers and a symptom appraisal and help-seeking e-tool for the public. And then in Workstream 3, we will evaluate the utility of the tools to ensure they're operationally and economically feasible, acceptable, and promote improved assessment, referral, and diagnosis of symptomatic patients. So in summary, cancer symptom appraisal, interpretation, and the pathway to diagnosis and care is really complex. Improving the pathway really does require a collective effort that involves the public, patients, healthcare providers, and managers, as well as other sectors. To make a difference to this journey, we also need to improve capacity in various aspects of neglected research, implementation science, qualitative research, mixed methods, health systems, as well as health economics research. There is potential for collaboration between social scientists, public health researchers, community and patient-based organizations, and policymakers, both in the health sector and beyond, in working together to improve the journey to diagnosis. And I'm hoping that we'll have some further collaboration between your department and our department to look at work in this journey, which is really a difficult one. And with that, I thank you and open the floor for questions and comments.
Thank you so much, Professor Moodley. And on behalf of everyone attending here this afternoon, I'd just like to give you a round of applause, really, for sharing quite a substantial body of work and no doubt incredibly timely, given the context that you shared with us. And also, I think initially a little bit disheartening in the sense that you know, there's still such a great lack of awareness, and that the journey to help seeking and getting care and treatment is so challenging, whether it be the various structural barriers that patients are facing, or whether it is the attitudes and beliefs and perceptions of those in their immediate network. So thank you very much for that, and amazing to see this work going forward with Awaken, sort of part 2 or 3 or 4. So all the best for that. Colleagues, we have a couple of minutes. Are there any comments or questions for Professor Moodley? Rizwana has her hand on. Yes, go ahead, Rizwana. Thanks.
Hi, Professor. Thank you so much for your very informative presentation. And, I concur with what Bronwyn has said. It's such an impressive body of research. And I think you've gone through it so systematically. And it seems as though you've got things planned out for the next 10 years already or something. So that's really wonderful. I'm wondering, specifically as psychologists, what role do you think we can play in collaborating with you? What role can we play within the patient's healthcare journey? How can we help patients get diagnosed earlier? Could you maybe speak a little bit about that potential for collaboration, how you see that playing out?
Yeah, thank you so much, Rizwana. Yeah, there's more than enough work, more than 10 years, and there's only one way to do that, and that's through collaborations. Having worked with psychologists, I just see the very different skills they bring. For starters, with the validation exercise, psychologists are much more familiar with this process than public health researchers, for example. So that's one definite skill. But then there's also the skill of doing this qualitative type of research and getting perceptions, working to develop messages that are meaningful and evaluate all of those. I think the perspectives that different people bring to it are really, really important. So to me, no one discipline can do this. We really have to work together, and everybody has a different skill set. And I'm hesitant to say that's the only thing psychologists or any particular person can bring, because it's only when you start the work you realize that having all these skills gives you a much richer experience and much greater chance of actually effecting change. Psychologists really have excellent communication skills. And so tapping into that has been invaluable for our studies. So I'm hoping that means that you're very interested in this, Rizwana.
I see.
Thank you for your presentation.
Sorry, Riz, we missed the end bit there. Well, at least the camera on my side got stuck. But thank you so much for that question. And then we have a question as well from Jackie Stewart. Jackie, go ahead.
Hi, Jennifer. I'm Jackie Stewart from the Division of Global Surgery at UCT. I was interested on your, well, first of all, amazing. That was such an interesting presentation. I really hope we're going to get the PowerPoint slides, because that was really, really interesting and amazing. One of the things that we've noticed at a community level is that community healthcare workers themselves are sometimes sitting with misinformation or lack of clarity around some of the sort of preventative tools, especially around the HPV vaccine, where their own children, they have chosen not to give the vaccine because of all those sort of myths that it's something to do, that then means that your children are sexually active and, they're only 9 and 11. So, we're insulting people by providing it. So even though, as you talk about those really high cervical cancer levels, some of the rollout of fantastic preventative programs are not being taken up because of those kind of things. And I was just wondering if you had come across that at all.
So not in this particular study, Jackie, and thank you for that question and comment, because we weren't in particular looking at myths related to HPV vaccination. But in other studies, very interestingly, before the vaccine was actually introduced, we did some formative work looking at what people's views were about HPV vaccination at the community, provider, and policymaker levels. And most people had not heard of the vaccine at that stage. But when we explained what it was, interestingly, the greatest myths were amongst the providers. And the barriers were more from the provider side. So I think we have a lot of work to do to dispelling myths, and not just community health workers. It's also amongst providers that have firm beliefs on what does or doesn't cause, or what should be done. And we really do need to work with all these groups. It's a real challenge with myths, because they get perpetuated and it becomes hard to break it. So I think we do need to understand the myths far better as well.
Okay, thank you.
Thanks, Jackie.
Right. I'm just quickly checking the chat as well. We have lots of compliments on your presentation. But if there are no more comments and questions, then what I would like to do is to thank you very much once again, and to wish you all the best with a substantial body of work. And I know from who's in the audience that there are a couple of us who may be interested in further conversations. So yes, I'm sure that from the department side, we'll be in touch and have a couple of students who are working in the field of either breast or cervical cancer. So some mutual discussions about what's going on would be helpful too. Ashraf, go ahead.
I'm just thinking, Bronwyn, Professor Moodley, thank you very much for your talk. Some of us have done some research on the psychosocial aspects of cancer, and I think it is such an opportunity for us to listen to you and to hear the work that you're doing. Perhaps we can arrange a follow-up meeting for us to come and see you with a view to discussing the trajectory of research in psycho-oncology, psychosocial oncology over the next while. Thank you. That's really wonderful of you to have given this talk.
Thank you so much. I mean, it's actually the reason for giving the talk is to have these collaborations. So I'll be delighted to speak further, to leave contact details, to have meetings. There is just so much to be done. And so we do need to do things collaboratively. Thank you very much, Ashraf.
Right.
Perfect. That's wonderful. All right. Thank you, everyone. And thank you, Professor Moodley, for your excellent talk this afternoon. And no doubt an amazing networking session as well.
Thank you so much. Thank you, Bronwyn. And thanks to everybody for your attention and your questions and comments. Okay.
Thanks
so much. Bye.
Bye.
Goodbye. Bye.